Well, hello, and welcome to the next installment of the GOG's Inclusion, Diversity, Equity, and Access, or IDEA Commitment Education Program. I'm Dr. Colleen McCormick, and I am thrilled to be joined today by my colleagues, Dr. Sharad Gawande and Dr. Leslie Randall, for today's IDEA Commitment discussion on advocacy. I would love it if they could both introduce themselves.
I'm Sharad Gamande. I'm a gynecological oncologist in Augusta, Georgia, at the Medical College of Georgia. I am the Associate Cancer Center Director for Clinical Trials and also a PI of one of the 13 minority and corp sites in the United States. And I'm involved in clinical trials and disparity research.
Thank you. And Dr. Randall?
Hi, everyone. I'm Leslie Randall. I'm a GYN oncologist at Virginia Commonwealth University, where we're also a minority and core site as well. And I'm the division director of GYN oncology and the CTO medical director. Also for the GOG partners, I'm a cervical cancer trial advisor. So diversity in trials is very central to everything that I do. So I'm really happy to be here.
Thank you. Well, thank you both for your time today. So great to be talking about this important issue. So I wanted to get us started by kind of talking about what does this mean when we say partnering with advocacy groups? What are we talking about? For both of you, let's start with Dr. Gamande. What does partnership really look like at your site?
So I think that national advocacy groups are really important because the online content is really good in terms of whether it's just a women's cancer website, looking at advocacy, or specific groups, whether it's a Latina group and for specifically looking at Native American Indians or African Americans. I think the content is really good. A lot of people can easily access that, and as a resource for our community, it's a very important thing. However, there are elements of that which can be better in terms of perhaps having a navigation system where they can actually reach out to a navigator to actually talk, because that makes a difference. And that reflects in what we do in our patient population, because often we have rural patient coming from rural communities, and we have a fairly large minority population that we serve. Many of them are tech savvy. However, they prefer more of a local approach with local support group meetings that we have once a month. And we have an organization which started in 2004, which is now a big nonprofit, through which a lot of the advocacy needs, and I can talk about it at length later, are met at a local level. But we have for our meetings invited advocacy or rather advocates from national groups to come down and speak to our patients.
Great, thank you. So it sounds like really kind of the local touch, the individual touch is really important in it for your site. Okay. Dr. Randall, how about you? What does partnership look like at your site?
It's interesting because it looks almost exactly like it does for Sharad. We have a bench community mantra at our cancer center, and that's under the leadership of Dr. Rob Wynn. And I think it's important to understand your catchment. I'm sure you clearly understand, who your patient population is, because that's who you need to connect with, and you're going to connect with them in different ways. They have different needs. The way that we've organized this at our site is that we have an Office of Community Outreach and Engagement, and we have nursing champions, we have physician champions, we have nursing navigators, we have lay navigators that make up this team that sort of addresses different aspects of how we connect with the community and what kind of information we bring to them and what they bring back to us. And we're engaged with them all the time. We're not engaged with them just when we need them or just when we have a trial for them. And we have a regular two-way street engagement with them, so that when we do have a trial, it's never the first time we're interacting with them. They know us. They We understand what their needs are. So that's how we've organized it. And it just, it does take, to do it well, it takes some coordination. And I don't know that you have to invest a lot of money in the folks that are coordinating. I mean, these can be like lay navigators, can even be volunteers. But this is not something that the physicians or the investigators can really do. I mean, you have to value it and champion it, but you can't execute it. So building that team that helps you execute, create that bridge to the community, and then just being constantly engaged is really how we have sort of made that framework.
That's really a helpful perspective. Dr. Gamande, it sounds like you also have really built that partnership. I really love that point about, it's not just when you need something that, you kind of go to the community to try to get what you need, but really this kind of, up from, kind of really focusing on the strengths and networks and also needs. Dr. Randall, is there anything that you kind of could point to say, like, this is how, how you identify what your community needs? Like, is it just like, oh, let me just hire somebody, or, what's been your experience with that?
You just have to engage with them. That's why it's the Office of Outreach and Engagement. You have to talk to them, and you would often, we were surprised to learn some things. I mean, we have assumptions, and we're often have good assumptions based on our experience with our patients. But when you open it up to a broader community, you'd be surprised to learn, what the needs are. I mean, I underestimated the need for education, huge need for education. I mean, these folks, they understand what we're doing, but they really want that sort of basic education. What is uterine cancer, for example? Who gets uterine cancer? What does that mean? How do these, patients, how does that affect people? How do they feel? Really interested in that type of education. So we learned that by just engaging with them.
Okay. I know that we've really focused on the importance of kind of this hyper local, understanding your catchment area, serving the needs of your patients. What experience do you guys have with like how partnership looks nationally, or kind of where you would like that to go, kind of from a bottom up kind of level? Dr. Randall, you want to take that first?
Sure. I mean, I think traditionally, especially the GOG, for a long time, we've had patient advocates on all of our committees, and they've been incredibly strong. I mean, they've made all of our trials better, I would say, and they've just been very strong champions and advocates of getting patients onto our clinical trials and making it feasible for folks and making it relevant, to them. So I think that's one major plus, and that's been going on for a long time. This new push towards improving the diversity on our trials, we see that coming through the FDA with mandates to improve the diversity of enrollment, because it remains, even with all the advocacy work, it remains pretty abysmal. I think it's gotten better in the last few years, but still so much work to do, from a pharmaceutical investment to provide resources for our patients to participate in trials like Sherrod, your rural population, which I don't really have so much. These are patients have to travel. They have to sometimes get lodging so that they travel on multiple days to participate in our trials. It looks like providing those resources from pharma. And lastly, diversifying our workforce. Dr. Nguyen also has a grant that helps train investigators of disadvantaged backgrounds, so that the investigators asking patients to enroll in trials look like them, understand their experiences, and are relatable to them. And it will just make the whole enterprise better. I mean, what enterprise has not been improved by diversifying, whatever it is? So I think, diversifying the workforce that allows that enrolls patients to trials is going to make a big difference.
Yeah, great. Well, thank you both. Well, I think now we have a good understanding of kind of what that partnership really looks like. Let's kind of, and we've kind of touched on some of these, you know, just with your last answer, but as far as, you know, the importance of diversity for trials and research in general. But I'd love to hear from both of you, starting with Dr. Gamande, kind of like why, you know, why you do this, like what benefits have you seen for your patients? Just you know, one or two concrete examples would be great.
Well, I think advocacy, you know, as just touch on what Leslie was saying, uh, is important when we connect with national groups. I mean, we've had speakers from both patient advocates through ASCO, SGO come here, and it has been a two-way street because some of the things which we have done, which we want to implement at a national level, would be a buddy system because as Leslie was saying, we have a diversity issue. Luckily, at our site, our enrollment for African Americans, for example, is almost 46% over the last 9, 10 years, which is not even congruent with our patient population, which is about 28 to 30%. But we have a buddy system where any patient on a trial, especially can talk with not with anybody, but sometimes in a racially congruent manner of why they are in the trial so that some of the fear or the misgivings of a trial kind of go away. And secondly, I think we underestimate the logistics of cancer care. Insurance is great, but we just did a study in our patient population, ran by one of my fellows, which is going to be an AI project, but we found out that despite insurance, the staggering cost of it takes and the toll it takes financially, whether the choices are doing co-pays or doing groceries or actually coming to all your appointments. And that's where I think at the national level, we should be able to get, especially pharmaceutical trials, to be a little bit more generous in terms of those kind of supports. And I think, and that's where this interaction would be very, very vital.
Yeah, those are such great points. You know, I know at UNM our patients travel for such big, like astronomical kind of distances that you know the burden of even a 6-hour infusion is makes anything a 2-day trip. So just having you add in a couple PKs that are 4 hours later and it's just not doable. But this buddy system I've heard you talk about before. It's just so amazing. Could you just give us a little bit more on kind of like how you think that could be translated nationally?
So I think that's where a little active websites where you just don't have an advocacy website, but you actually have a navigator who can connect patients with a HIPAA form that's signed by the patient and the participants. Even a phone call, because I have some people who cannot come from my support group. I have somebody say with ovarian cancer and brain mets, but I can absolutely get a patient who lives 4 hours away to call the patient, talk to them, talk about the anxieties of getting radiation and survival in that situation. And that absolutely can be replicated because clinical trial population is small, it's finite, and I think if we make it a priority, it should be something that organizationally we can try to advocate for and be help implement.
Just so amazing, like such a great tool for your patient population. Would be so wonderful to be able to really ramp that up, kind of again that like take the strength of what's happening and take this amazing strengths that our patients really have. How about you, Dr. Randall? Have it's kind of what's your why here?
Well, gosh, I mean, for me, it's just, for me, it's a little political, not to get too political, but I mean, this is an injustice, right? This is an injustice for patients not to have access to these studies and for, the medical community to allow this, like, this Tuskegee thing to persist. Like, the bottom line is these patients are not gaining access to life-saving therapies. So to me, it's just the justice of everyone having access to something that's potentially life prolonging or life saving. And this buddy system, gosh, I have to comment, like, I really think it's interesting to look at the numbers. So you're with the buddy system, you're accruing twice as many Black patients as you have in your catchment. So we are accruing half of our catchment without a buddy system. Um, but we're still at 26% Black African American, which is much higher than the typical 4 to 6% across the board. But I'm really listening to you and hearing, kind of comparing notes and see that, wow, this buddy system is probably, and I don't know if you feel this way, but maybe what kind of got you over that hump or created that bridge, that delta.
No, though that is a huge part of it because I think the biggest thing it cancer, whether it's regular treatments or clinical trials, is fear of the unknown, fear of making this step into something you are really not familiar with. But
Mm-hmm.
being able to talk to somebody who's been there, done that, that you can reach out and call or have a cup of coffee and talk about it, then in face to face or online or at the phone call, makes a tremendous difference in trying
Mm-hmm.
to get away the fear, the reluctance, the ideas of it not being fair, out of the equation. I mean, that's a part of what I think, has really helped us, apart from a variety of things, as you had brought out earlier in the grant that you have, Leslie, at your institution, having racially congruent people there, whether it's navigators and nurses, gets a sense of comfort to the patients walking into the place. Well, there are people like me who are actually helping out. I think that makes a big difference. We have also gone out to the community, done seminars in different churches and stuff like that, saying that this is your cancer center. It's not
Mm-hmm.
something come as a last resort, to come here as a first resort. So some of the few things that we have, I think, done well locally.
Yeah, those are just great. I just think about all of the data that's coming out about how like loneliness and separation and kind of loss of community, like it just really breaks down our society. And I think, that's especially evident when somebody's, in extremis from, needing cancer treatments, or the financial impact, or just, the mental impact that, being able to kind of really help foster that community. Good research shows that it's kind of those senses of isolation that decreases patients' ability to, comply with treatments, or, be able to get there, to be able to think about a clinical trial. It's hard to think about enrolling in a clinical trial if you're really worried about, is your electricity going to get shut off? That kind of like sense of isolation and doing it alone is so paralyzing. That's
Mm-hmm.
really. Yeah, I think it's also really important, that point that you brought up about injustice. It's not just to the individual patient who, doesn't have access to that clinical trial, but then the flip side is that our clinical trials and the treatments that we have don't reflect the patients who need them. And so
Mm-hmm.
then we don't know, are they going to work in, patients with a slightly different molecular profile, or patients with a slightly different, kind of genomic, changes. It's really important, not just for, the patient who can or cannot enroll in the trial, but the patients down the road, to make sure that our trials our meds are actually applicable. So, yeah.
Yeah, it's such a great point. I mean, we've even started like IITs at our institution of just kind of backfilling the data for just these populations
Yeah.
and certain, novel agents that are already commercially available, but we just don't have the information.
Yeah.
Yeah, that's such a great point. And I mean, what kind of a resource drain is that to like go back and go move backwards, and you know, they'd be better off kind of getting to move forward.
For sure. Well, I think we've really kind of focused a lot on the how, but I know that folks watching really, uh, you know, get very excited and say, yay, I should do this. This is great. But, if you have somebody who's sitting there and says, gosh, I'm just getting my clinical trials program ramped up and I want to like do this right. What like one point would you say somebody who's just starting to kind of figure out how to partner with the community and community advocacy groups? Like what would you tell them to do as their first step? Dr. Kamande, you want to take that first?
Sure. I don't think really, to be very honest, you can build that specifically for clinical trials only. It's got to be
Mm.
a part of a larger program. The surprising thing for me is I'm practicing in not necessarily a large city, but I've been absolutely overwhelmed if you have the right message, how much community support there is in funding a variety of activities. So I think probably a parallel but an important step is to start a support group. Start the educational process. As you said, one of the things is about feeling alone, fear of recurrence, trying to do education. Those are important parts. And more as you empower these patients, they're very likely to jump into clinical trials because now they have a sisterhood, if you will, of patients who understand them better than almost anybody else can do. I think that would be a first step, and in parallel, cultivate the local sites, local resources, which are nonprofits which are existing there, working out with churches, getting a very succinct message out there as to why you want this to be a community of hope for the entire community that we live in.
I really love that, a community of hope. That's such a nice way to put it. Dr. Randall, what advice would you give somebody who's enthusiastic but doesn't know where to start?
Yeah, I would mirror exactly what Dr. Gamande suggested. I think that's what you do, and I think the most important thing is get yourself a coordinator, because you're not going to have time to run and coordinate this, and it will just delay getting it off the ground. So, the coordinator has to be someone who is invested in this mission, right? They understand the importance, they are able to see where the community connection opportunities are, and then that helps you sort of build that community network.
And just to be clear, you're talking about like somebody whose job it is to kind of
Yeah.
communicate and coordinate with the community rather than like a nurse navigator kind of spot or, okay. Yeah, that's
Right.
great.
And, if you don't have funding to create that position, there are a lot of folks in the advocacy community and the survivorship community who would volunteer. And you may need more than one, they may not have time if they're volunteers. You may need multiple folks to kind of share the workload. But I would just kind of start small and just start to build from there, as Dr. Kamandi suggested. And I think I'm always amazed at what these folks, they just take off, it just takes off organically. And it's really, it's responsive to what they need and their communication styles. And it's really a great thing.
That is really lovely. I think, great starting points for kind of this topic. Um, so, I just kind of to sum up here, what we've talked about, that, partnering really kind of improves trials, but just like Dr. Gandhi said, it really actually just improves like all of our healthcare, all of our patients' cares, certainly enriches, our experiences as doctors. It certainly has for me. Kind of this bridge of like improving enrollment, but then also again, kind of that bottom up, improving the diversity of our trials and our work. Any kind of final points for our audience here? I think I have started with Dr. Kamandi last time, so I'll lobby it to you, Dr. Randall.
Yeah, I think we have to rely on people that are not us to
Mhm.
execute this, right? Because you know, we want to be the heroes. We want to do everything, and we're invested, and we want to be the ones who execute this. But I think that we really have to step back from that a little bit. I mean, we're a champion, we're a leader, but we're not the. I don't think we're the best folks to execute this. I mean, I feel like my patients are afraid to tell me a lot of these things, that they have concerns. They don't want to bother me with it. They perceive that, you know, I'm too busy, and sometimes I am too busy. You know, they need someone that can sit down with them. They also don't want to be judged. They feel ashamed. I mean, I feel ashamed telling my doctor how many times I didn't take the medicine I was supposed to take. So I think that because I was in the OR or whatever, but you know, I think creating that community where they can communicate freely their actual concerns, so that we know what they need. Because I think that if you leave that to the doctor patient, you're not going to know what they need, and you can ask them. They're like, "Oh, I'm fine. I'm good." You know, they're just grateful to have your care, and they're not going to burden you with these things. But, you know, if I could leave you with anything, it's just that, you know, we don't have to be the ones who execute this process, because we're not the right people to do it. It needs to come from the community.
Yeah, I think that's, you know, so often, especially in GYN oncology, I feel like we're like, oh, I can get these things done, and I'm just gonna fix this problem, you know, and it's really important to kind of see the strengths of the community around us and kind of figure out how you can be how you can acknowledge that and, you know, kind of give it a space to grow, and to make sure that you foster it and are supportive of it, but not like feel like you need to be the savior. So that's a
And
really good.
one final word on that, like, it will create a community for you. It
Yeah,
creates a community for us. I know, I'm sure Dr. Gamande is, I mean, this is his community that he's created, this wonderful community network. And it's probably, I would imagine, enriched his life as much as it has his
No,
patients.
absolutely. I'm going to make a comment to that. You're 100% correct. It's made not just me, but my staff so much more sensitive, better people in general, because we spend
Mhm.
a lot of time with the patients outside of our workplace. But I'm going to end up with three words. One is commitment, second is community involvement, and thirdly is persistent. If we do those three things across the nation, I think we can make a big difference in this slide in terms of getting clinical trials accrual and doing right essentially with the patient population that we're looking.
great. Well, with those three words, we're gonna wrap up here. Thank you. Both. Here are a couple hyperlinks to kind of national organizations, which can be a good place to start. A lot of times these groups have, you know, smaller local groups that can be something that you can kind of tap into. And then, of course, always visit the IDEA commitment site. And then again, special thanks to our sponsors, GSK and Immunogen, who allowed us to give this presentation today. Thanks, guys.
Okay. Thank you.
Thank you very much.